Good afternoon, and thank you for joining us today. The last few times we've met, we've mostly shared bad news, and there's no running away from it. The situation is still grim. However, today we get to share some good news with you. As many of you know, the first batch of Pfizer vaccines have arrived in the county and have been distributed to hospitals to begin the process of vaccinating frontline healthcare workers. Meanwhile, the federal government has approved the Moderna vaccine for use, and we expect to start getting shipments of that shortly, along with the second shipment of Pfizer vaccines. This is truly a critical turning point in our long fight against this global pandemic. But as we get out these vaccines, it's critical to remind ourselves that the fight against COVID-19 is certainly not over. The first dosages of the vaccine will not be enough to reach all people in the county. So it remains essential that all of us continue to do our part by continuing to cover our faces, washing our hands, and avoiding large gatherings, especially during this holiday season. As you'll hear soon, our region's hospitals are maxed out with patients, and we need to do what we can to avoid overwhelming the healthcare system so that they can treat not just COVID patients, but people suffering from other illnesses and chronic diseases. We haven't crossed the goal line yet, so let's not spike the football. I also want to emphasize that the county is not rolling out the vaccines alone. We are working with our hospitals, health clinics, our community partners to get these vaccines to groups of people that have been determined by the federal government as priority recipients. We know there are a lot of questions about that process, and today we will go through the steps of the rollout to try to address any questions. First, we'll have Supervisor Fletcher, and then we're going to have with us two guests today, Dr. Gail Knight, who is the Chief Medical Officer of Rady Children's Hospital and is the co-chair of the Hospital Chief Medical Officer COVID-19 Advisory Group. She'll be available if there's questions. She'll be, and then Dr. Ankita Kadakia, I hope I get that fairly close, the Chief Medical Director of the county's Public Health Services Tuberculosis Control and Refugee Health Branch, is with us to provide some insights and answer some questions. The County of San Diego's COVID-19 Vaccine Critical Advisory Group brings together local and community clinical partners to provide guidance using the phased approach for vaccine distribution and to provide recommendations using a health equity lens when vaccine supply is limited. We appreciate their help and appreciate Dr. Knight and Dr. Kadakia for being here today. Now, please welcome Supervisor Nathan Fletcher.
Thank you and good afternoon. The Thanksgiving holiday season has hit us really hard. A significant increase, record numbers of cases, massive increases in hospitalizations and significant jumps in reported deaths attributed to COVID. And the reality of the situation we face is our hospitals are struggling. Our healthcare workers are struggling. We are seeing a series of actions that are designed to try and alleviate the pressure on our healthcare system and ensure the availability primarily of our ICU intensive care unit beds. We've seen changes in ambulance diversions. Hospitals have told me directly that they are delaying tumor removal for cancer patients in an effort to make a bed available for a COVID patient. Hospital CEOs have said that they have delayed organ transplants in order to make a hospital bed available for a COVID patient. Our inability to control the spread of COVID-19 is causing hospitals to take extraordinary actions in order to free up space. COVID-19 is having a negative impact on the ability of others to receive the care that they need. And again, these are cancer patients. These are individuals in line to get an organ transplant. These are serious healthcare issues that are having to be delayed in order to make the availability of that ICU bed in particular for those COVID patients, and we have to get this virus under control. We simply have to take action to change the trajectory of where we are. In addition to everything they're doing, our hospitals continue to face tremendous challenges around staffing. It is part global strain on the availability of healthcare workers. It is a little bit of burnout. It is some healthcare workers getting infected themselves and having to isolate or quarantine. The staffing challenges are real, and it could mean that we may not be able to actually staff the available ICU beds that we have today. Our hospitals are asking for help from the state of California with staffing resources, and they are being incredibly creative in how they can reallocate and remove things around. They are doing everything possible to ensure the availability of that. And it's important to remember that even if you think, well, I'm not going to get COVID, or if I do, I'm young and healthy, or well, that's fine, I'm not a cancer patient, or I don't need an organ transplant. If you get in a car accident, you're going to want that ICU bed to be available. And so the actions that we are all taking as a community are designed to continue to be able to ensure that we can do that. But with another holiday on the horizon, in less than 10 days, we will head into the Christmas season. We have to take action different at Christmas than we did at Thanksgiving. If our individual choices and actions at Christmas resemble those at Thanksgiving, we very well could overwhelm the system that we are holding together on a daily basis. And so we are pleading with the public, please observe this holiday season safely and responsibly. Please do it with members of your own household. We aren't giving up large family gatherings around Christmas forever. We just are doing it this one year. At a point at which we are on the path to coming out of this with the beginning of vaccine, we need to finish strong, and we need to come together this year. Our actions that we take in the holidays are a down payment to put us in a better position after the first of the year to be able to come out of this strong and prepare for the arrival of large numbers of vaccines. But we aren't just taking actions in order to singularly preserve the hospital capacity, nor are we taking actions singularly to help get us in a position to be able to open more business and get more kids back to school. We're taking actions to save lives. Yesterday, we reported 32 additional COVID deaths. Today, we're reporting 23 COVID deaths. There are now more than 1,200 San Diego families who have lost a loved one from COVID-19, more than 300,000 across our country. We have to take action to protect our hospital system, to protect our small businesses and our economy, but also to save lives. And we hope that everyone will come together as we try to get through this very difficult time we're facing. As was mentioned by Chairman Cox, San Diego County received the first allocation of vaccines, 28,275 vaccines. And in order to provide a clearer understanding of the process for distribution of vaccines, and in particular, the distribution of vaccines today with what we have here, we're going to walk you through the process. I'm going to preview a couple of the slides and give some of the information, and then you're going to hear from Dr. Kadakia, who is Director for Public Health Services at the county, but also one of the 3 tri-chairs of the county's Vaccine Clinical Advisory Group, who can also provide more insight and information in greater depth about the process that we are all working through. We appreciate Dr. Kadakia's work. She's been with us throughout the duration of this, working behind the scenes daily, and has stepped up and is playing a leadership role in the vaccine efforts, and we're grateful for her work, along with Dr. Knight, who is here from Rady Children's Hospital, again, one of the tri-chairs of our clinical advisory, and also incredible work that they are doing at Rady. But obviously, before we got to the point of having a vaccine today, there was considerable effort that went in by scientists, by our drug companies, to create the vaccine, and they went through an exhaustive federal approval process to get us to a point of an FDA-approved vaccine. Now, it is important that the public know that while the process was faster than normal, it was because of the unprecedented availability of funds and resources to be able to go through all of the normal safeguards and procedures in a quicker timeline. There were no steps skipped of what would happen in a normal vaccine process. They were just done more swiftly. In normal vaccine development, you have a sequential process where you do something, you wait, you do something else, you wait, you do something else. But because of the availability of billions of dollars that were injected in to get this done quicker, each of those steps could be done simultaneously instead of sequentially. And so we arrived at a vaccine faster than we ever have before, but not because corners were cut, not because it wasn't studied, not because it wasn't researched, but because of the desire and need to get this done quicker. And so we have great confidence that the vaccine is safe, that it has been reviewed, and that it is something that every member of the community should take. And as we work our way through the vaccine distribution process, we will continue to communicate that, to work with trusted partners, to share information and be very transparent. But once we got the sign-off, the vaccines at times go from the federal government directly to sources that will administer them. Sometimes they go to the state sends them directly to sources that will administer them. And then in some instances, they come to the county, where in some cases we will do some ourselves, and often we will also provide them to other entities that will do that. And Dr. Kadaki is going to walk through some slides about the distribution process. I want to focus today on who is going to get the vaccines, and in particular in what order. And I will tell you that the process is a little clunky with tiers and phases. We didn't design it. This was designed by the CDC. So bear with us as we try to walk you through and share with you an understanding of what it looks like. So let's go to our first slide here. What you'll see right here is the 3 phases of vaccine distribution as created by the Center for Disease Control, CDC. Phase 1, Phase 2, and Phase 3. You see there in Phase 1, first we're doing 1A, healthcare workers, along with long-term care facility and staff residents, the red box. That's where we are right now. When we complete this, we go to 1B, essential critical infrastructure workers. You complete 1B, you go to 1C, adults with high-risk medical conditions and adults age 65 and over. Once you complete those, you're done with Phase 1, and then we go into Phase 2. Children and young adults, 30, other critical workers, you complete Phase 2, you go to Phase 3. So that is what the totality of the process will look like, and we don't know how long it's going to take because we don't know when we will get how many vaccines, but we know the order in which we will work through them. But what is primarily important is where we are today. And so let's go to the second slide and let's look at what Phase 1A. This is what we're looking at now. These are all of the folks that we will treat in the first batches that come in, and this is the order in which we do it. Again, we've broken it out of an effort to be incredibly transparent around all of the sequencing of what we will do. So you see there where we are in the red box. This is who is getting vaccines today. Acute care, psychiatric and correctional facility hospitals in San Diego County. Now, it's important to note, we don't have correctional facility hospitals in San Diego County. If an inmate needs a hospital-level care, they are transported to a hospital and then returned. And so essentially what we are doing right now today in the red box is those staff that are at acute care, hospitals, and psychiatric facilities. When we get done with those, you can see the order at which we will continue to progress from the top of your screen down to the bottom. Now, how many folks are in this red box that are getting the vaccines right now today? Let's go to our next chart. There are 82,623 San Diegans who are healthcare personnel working in acute care, psychiatric, or correctional facility hospitals, with the understanding we don't have that third category. So 82,000 in San Diego County, healthcare workers in acute care or psychiatric settings. Out of these, again, we're going to go based on their risk. 1, 2, 3, 4. Those 4, as we run through based on risk, will get us our 82,000. To date, we have received just over 28,000 allocations of vaccines to the San Diego County region, and those are going to the individuals you see there in the red box. The highest risk individuals, healthcare workers in acute care hospitals and psychiatric facilities. Now, you need 2 shots, 2 doses of the vaccine, the Pfizer vaccine, separated by 3 weeks. We got 28,275, and the state held back an additional 28,275 that will arrive at the appropriate point so those same individuals can get their second dose. As we get more batches of vaccines, that will be the first one. They will also be holding back the second one to send those a few weeks later, and we have a registry and tracking system to ensure that everyone who got the first one can come back and get the second one. So again, this is where we are today, and you can tell we've got a fair amount of work to do. We've got to get a significantly larger number of vaccines just to be able to cover our healthcare workers in acute care and psychiatric facilities. And then after we complete this, then we will go down the line that we've shared with you and the sequencing of what we have in front of us. So there is a lot of thought, there's a lot of questions, that's understandable, but what we are doing is administering the vaccines we get with the plan we have in place for the folks who need it most, and we will continue to work through this process that has been created, again, at the federal level, and is important for us to follow that and continue to go, along with providing updates about what we know, with how many we have and what we expect to get. Because we have so much to get through today on vaccines, I'm going to simplify the charts I normally do. I will share with you today, we are reporting 2,807 new positive COVID-19 cases, our second highest total to date of the pandemic. The two charts I do want to share with you, and all of our normal information will be available on the website, but for the sake of time, I want to be sure we have enough time for all of our presenters today to get to. But I do want to touch on our hospitalization chart, which you can see right here. And again, this brings to mind that the scope of the challenge we face. These are just COVID-related hospitalizations. You see the significant increase in COVID-related ICU utilization, and then you see the significant increase in total COVID-19 related hospitalizations. And again, hospitals are working to free up capacity by delaying care that other individuals need. But again, we shouldn't be of the mindset that these are just elective things that you can do anytime. Some of these are things people need to get done, and it is impacting the ability of San Diegans to get the care they need in order to try to make space for our COVID-19 patients. The next chart you'll see here is just our ICU capacity, and again, as you continue to see that blue number increase significantly, what you'll notice is that other ICU census continues to get smaller. And this represents individuals who are not going into the ICUs for treatment because hospitals are making adjustments. And again, I want to point out that although that ICU bed capacity stands there at 696, there are very real staffing concerns and challenges and questions about the availability to get to that number. And we're doing everything we can to be as creative as possible in supporting our hospitals and utilizing state resources and trying to bring on other things that might help get us through this difficult period. But this really brings home to us the importance of taking decisive action to try and slow the spread. That concludes my report. I'm now going to turn it over to Dr. Kadakia to provide more information and walk through, again, the vaccine information. We know the tiers and stuff, it's a little bit clunky, but if you bear in there, she's great at explaining things in a way even I can understand. And so please welcome Dr. Kadakia.
Good afternoon, everyone. Dr. Kadakia will follow me to go over the various phases. So thank you, Supervisor Fletcher. And as everyone is aware, COVID-19 cases have drastically increased during the past months across the nation. Daily coronavirus deaths in the past week topped the worst days of the spring surge. As of yesterday, more than 303,797 Americans have died from COVID-19. There have been 16.7 million confirmed cases in the United States and 73.5 million cases worldwide. Nationwide, in the next slide, there has been the deadliest week of the coronavirus pandemic. As of yesterday, the U.S. COVID-19 deaths have surpassed over 303,000 at 303,797 deaths, which is more than the number of deaths during the U.S. battle deaths of World War II, which topped at 291,557. This is disheartening news. These are not just numbers, they are people. And they are someone's mother, someone's father, someone's sister or brother, or someone's aunt or uncle. In the slide number 3, just imagine filling Petco Park more than 7 times and having those people die from COVID-19. Well, that compares to the total number of U.S. deaths to date at, again, 303,797. Now, in this next slide, the deadliest single days in American history are shown on this slide. And on Friday, December 11th, COVID-19 deaths was 3,306, which is third to the Battle of Antietam, which had 3,650 deaths, and then the Galveston hurricane at 8,000 deaths. So think about that for a moment. And there have been other days in the past 2 weeks where COVID-19 deaths have exceeded 2,000 or more. So we have seen rising daily cases also reported in the 1,000s since November 14th. And recently, since December 3rd, in the 2,000s, the numbers have occurred, as you can see here. For 6 days straight, from December 18th to December 13th, San Diego has reported over 2,000 cases. The record high is now at 2,867 cases on December 10th. Today's case count in the next slide is 114,248 cases, now well over 100,000 cases, which is 2,807 more cases than reported yesterday. The age range of cases is from 0 to 107 years of age, which is unchanged. And the other demographics are essentially the same. We're at 57% of the age group 20 to 49 years of age. 58% of cases have been in the Latinx population. And for gender, 51% of cases are female and 59% are male. And 5% of all cases have been hospitalized. The number now is at 5,251. This is cumulative, but in just a few minutes, I will review what has been happening in the past months with hospitalizations and ICU admissions. 1,123 of those individuals that have been hospitalized have been admitted to the ICU. This number is approximately 1% of the total number of cases and 21% of the total number of those hospitalized. The total number of cases includes deaths at 1,217, which also represents 1% of the total number of cases. We have had 23 new deaths reported since yesterday. Now, of the 1,217 deaths, 1,169 or 96% had underlying medical conditions, and the top 3 conditions remain unchanged from previous reports, including hypertension is number 1, diabetes number 2, and heart disease is number 3. Now, as cases continue to increase, so do hospitalizations and ICU admissions. Comparing in the next slide, for the 7-day period from 12/9 to 12/15, comparing that 7-day period with the previous 7-day period, 12/2 to 12/8, there has been a 22% increase from that first 7-day average to the second. So this has decreased somewhat. Previous percentages for this particular slide has been 33%, but the numbers are still increasing and challenging our healthcare system. Locally, I will briefly, in another way, review the hospitalizations and ICU status during the last 30 days, the last 14 days, and the last 7 days. So in this next slide, from November 16th to December 15th, there was a 227 increase in hospitalizations over this 30-day period. There was a 155% increase in ICU admissions for the same period. From December 2nd to December 15th, there was a 54% increase in hospitalizations for this 14-day period and a 41% increase in ICU admissions. From December 9th to December 15th, there was a 24% increase in hospitalizations for this 7-day period, with a 26% increase in ICU admissions for the same period. Now let's move on to outbreaks. In the past 7 days, we are reporting 43 total community outbreaks from December 9th to December 15th, representing a total, go back please, representing a total of 100 and, next slide, this slide, thank you. Representing a total of 168 cases. Now in the next slide, there were 6 additional outbreaks reported from yesterday, which were in the following settings: 4 in daycare, preschool, and child care settings, 1 in a business setting, and 1 in a healthcare setting. I included this next slide just to show why vaccinations in our phase 1A tier 1 is including long-term care facilities. If you look on the far right, 32% of all deaths, which includes SNFs and non-SNF congregate settings, have occurred during this pandemic. So 32% of all deaths is the rationale for including long-term care facility residents as well as staff to be vaccinated. In the next slide, moving to Blueprint for a Safer Economy, which is the tier framework. The system is based on levels of disease transmission by widespread, substantial, moderate, and minimal, which represents tiers 1 through 4 respectively. This slide shows the state's progression since the beginning of November. Now we have approximately 54 of the 58 counties that are now in the purple tier. In the next slide, the county's COVID-19 unadjusted case rate for the week of November 29th to December 5th is 52.7 per 100,000 population. The adjusted case rate is 29.5, and the state's calculated test positivity percentage is 10.9%, and the county's calculated same metric is 9%. The county also continues to calculate the health equity positivity percentage, which is at 13.5%. Now, on December 3rd, in the next slide, California issued the regional stay-at-home order to stop the surge of COVID-19 cases and prevent a strain on our healthcare system. And on December 6th, the regional stay-at-home order went into effect for Southern California region since the ICU capacity was less than 15%. All counties are categorized based on the 5 health officer regional coalitions, and collectively an ICU capacity metric is calculated for each of these regional coalitions. Since last week, the ICU capacity has dramatically decreased, and there are now 4 of the 5 regions in the stay-at-home order with less than 15% ICU capacity, and you see the list there, with Southern California being second in terms of the metric at 0.5%. Now, in the next slide, San Diego is under, as I stated, the Southern California region, along with 10 other counties. After the 3 weeks period for the stay-at-home order, the ICU metric will be projected out for another 4 weeks, and this percentage must be above 15% in order for the regional stay-at-home order to be lifted. However, at the rate that our daily cases are occurring, we do not anticipate that we will see much of a change beyond Christmas, and we feel that this will still follow over into the beginning of the year in January. Now, I know the stay-at-home order is demanding, but remember, this will help ensure that those who need care, particularly in ICU units, since hospitalization and ICU rates continue to rise. Now, on this slide, I just want to share, stay on the last slide. I just want to share some information that was recently released by the state in the next 3 slides. This first is regarding California healthcare staffing. And on Friday, the state issued a waiver adjusting nurse-to-patient ratios to help with staffing needs in some facilities. And those facilities or types of facilities include ICU units, step-down units, telemetry units, emergency medical services, as well as medical and surgical units. In the next slide, and actually, I didn't mention, though, if you can go back to the last slide, currently the nurse to ICU patient ratio was 1 to 2% before the pandemic. And now currently, with this guidance issued by the state, the allowance is now 1 to 3. in terms of that ratio. Now with the next slide, the state's Vaccinate All 58 campaign was also launched this week. And the guiding principle here includes partnering with the diverse communities, community-based organizations, and engaging trusted messaging to share information with the general public and providing fact-based messages to make informed decisions. And the County of San Diego is doing all of this as well. And please look for our webpage related to COVID-19 vaccinations that will be posted at the end of the day. And then next, there was also a new quarantine guidelines that was released. And it includes a decrease from the prior 14-day quarantine period, which has not been eliminated. 14 days is still required unless these additional requirements or actions can be taken. So 10 days for all asymptomatic individuals exposed during critical staffing shortages, 7 days for those that were exposed or healthcare professionals that were exposed, emergency response personnel, and selected social service workers, if they have a negative test on day 5 or later. And then all of the individuals must continue to wear a mask and comply with other necessary PPE requirements, maintain physical distance, and self-monitoring symptoms. Now, please remember, we are all still in a pandemic, and these evidence-based strategies, when implemented, have been proven to reduce the chance of contracting COVID-19 or transmitting the virus to others. And these are the common actions that we recommend every week. And if you're sick, we know the 3 W's: wash your hands, watch your distance, and wear your mask. If you're sick, we want people to stay at home. And if people are sick, we want them to get tested. Now we're adding another component, because we now have vaccines, is to get vaccinated. We don't want people to get vaccinated if they're sick. People who are infected can get the vaccination 90 days after their symptoms resolve. But we want all individuals that have no symptoms, when their time is ready, to get vaccinated. Right now, our focus is on acute care hospital or acute care personnel in our hospitals and psychiatric facilities. And Dr. Kadakia will talk about that shortly. Now, lastly, is there a next slide? So this slide will open up for Dr. Kadakia. But I just want everyone to remember that this afternoon the county will publish pages on the coronavirus-sd.com with information regarding COVID-19 vaccine that provides information on the phased vaccination approach and our local COVID-19 clinical advisory group. And Dr. Kadakia will go through all of those elements. General information about the vaccine and information specifically for healthcare professionals will also be included on the website. Now, please welcome to the podium Dr. Ankita Kadakia, who is our Chair for our San Diego County COVID-19 Vaccine Clinical Advisor Group, and she's also our Medical Director and Chief for the Tuberculosis Control and Refugee Health Program. Thank you.
Good afternoon. The next few slides are an overview of the vaccine process, including distribution and allocation of vaccine for San Diego County. Allocation is the determination of the number of vaccines that go to a facility. CDC allocates vaccine doses to the California Department of Public Health, also known as CDPH. CDPH announces when enrollment is open and COVID ready. This is a website from CDC, but CDPH manages for the state. the County of San Diego provides support as needed for providers and healthcare systems to enroll into the COVID Ready website. This does not include multi-county entities such as Kaiser, federal entities such as the military, and pharmacy partnership program. CDPH determines the number of vaccines to local regions. And again, the county allocates vaccine based on the available supply to COVID-ready enrollees. Next slide, please. Distribution is the giving of vaccine to facilities. CDC distributes vaccine and ancillary supplies, so these are the supplies needed to administer vaccine, directly to federal entities. This includes Pharmacy Partnership Program, the military, and other federal entities. CDC also distributes directly to approved COVID-ready enrollees. CDPH identified multi-county entities and will distribute to them directly. The County of San Diego also receives vaccine directly from the CDC and distributes vaccine and ancillary supplies to entities that did not receive vaccine directly from the CDC. The distribution is to other COVID-ready enrolled providers who may not have storage capacity for vaccine or ultra-low temperature freezer. Additionally, the county is distributing to some hospitals and county-administered vaccines. Next slide, please. How vaccine will go to different groups is by phases, which were determined by the CDC based on recommendations from the Advisory Committee on Immunization Practices and the National Academies of Sciences. There are 3 phases, but phase 1 is broken into 3 sections, 1A, 1B, and 1C. Phase 1A is healthcare workers, including long-term care facility healthcare workers and residents of long-term care facilities. Phase 1B are essential critical infrastructure workers. And Phase 1C are adults with high-risk medical conditions and adults over the age of 65. Phase 2 will be children and young adults 30 and younger, as well as all other critical workers who did not meet the criteria to be in Phase 1B. Phase 3 will be all other individuals living in the United States. Next slide, please. The State Community Vaccine Advisory Committee and the Drafting Guidelines Committee further broke down Phase 1A into 3 tiers. Tier 1 currently are focused for vaccine allocation, and vaccine is only being allocated to the highlighted box in red, which includes acute care hospitals, psychiatric hospitals, and correctional facility hospitals. But of note, we do not have any correctional facility hospitals in San Diego County. Skilled nursing facilities and long-term care facilities, paramedics, EMTs, and dialysis centers are included in Tier 1. Tier 2 includes federally qualified health care centers, as well as rural health centers, correctional facility clinics, and urgent care clinics, intermediate care for persons who need non-continuous nursing supervision and supportive care, home health care and in-home supportive services, community health workers, including promotoras, public health field staff. In the next tier, Tier 3, this includes specialty clinics, lab workers, dental and oral health clinics, and pharmacy staff that are not working in settings in either Tier 1 or Tier 2. We are still in the process of determining the population numbers for each of these additional categories below the red box for Tier 2 and 3. And as we receive more vaccine and are provided additional guidance, we will continue to move through these tiers and the rest of the phases with the ultimate goal of being able to vaccinate all. Next slide, please. The state asked hospitals to provide the numbers of individuals who fall into the very first line of Tier 1 and Phase 1A. This is healthcare personnel in acute care hospitals and psychiatric hospitals. It also includes correctional facility hospitals, however, we do not have any in San Diego. The total amount for this group is 82,623. The state provided categories to break this group into further down into number 1, highest risk individuals, number 2, high risk individuals, number 3, medium risk individuals, and number 4, low risk individuals. The highlighted number with the red box is for highest risk individuals, which are frontline clinical staff who care for patients in high-risk settings or for patients with unknown COVID-19 status in high-risk settings. This could be an emergency room, intensive care unit, urgent care. This amounts to 39,755. Our first allocation of vaccine to San Diego region is only 28,275, which will not even cover the highest risk individuals of Phase 1A Tier 1, but all 28,275 doses will be distributed. The second doses of vaccine needed to complete the 2 series of vaccine required will arrive soon and will be an additional 28,275. So all the individuals who received their first dose will receive their second dose of vaccine. As additional vaccine is sent, we will continue the allocation and distribution process to get through all the phases and tiers so that everyone can be vaccinated. Next slide, please. The county COVID-19 Vaccine Clinical Advisory Group is tri-chaired by myself, as well as Dr. Gail Knight, the Chief Medical Officer at Rady's Children's Hospital and co-chair of the Hospital CMO COVID-19 Advisory Group, as well as Dr. Rodney Hood, the founder and CEO of the Multicultural Health Foundation, physician at San Ysidro Health Center, member of California Governor's COVID-19 Vaccine Task Force, and the chair of the San Diego County COVID-19 Equity Task Force. This group is made of collaborative clinical leaders from the county and community, individuals who work with vulnerable and underrepresented populations. We are collaborating to provide guidance to allocation using a health equity lens. I will now turn it over to Supervisor Cox. Thank you.
Thank you, Dr. Kadakia. We'll go right into the questions now, and I know we've got a number of questions lined up already.
Under Sowers, KUSI.
Hi there. Yeah, I was hoping if Dr. Wooten could explain more about why we're having this infection surge of new cases, second highest number again today. It seems that more people are following the rules. We know the stay-at-home order has been in effect now. So what is not working? And then my second question, do we have an idea of a demographic in terms of things like the age or gender of those populating the hospitals and filling ICU beds?
Okay, Dr. Wooten's going to respond.
Thank you for that question. As we've continued to share at all of these briefings over the past, actually 6 weeks, the numbers are increasing because people are not adhering to the stay-at-home orders. That's one of the major factors. The age group between 20 and 49 years of age has the highest number of cases. The older population age group has the lowest number of cases overall when you look at the cases, but when you look at hospitalizations, close to 80% of those hospitalized are 50 years of age and older. And obviously, with the underlying medical conditions, that increases one's a risk for developing complications, but we know that younger individuals with no underlying medical conditions also can end up in the hospital. So again, large gatherings, not adhering to the health officer's order, that really is the problem. If you go back to July, we saw a precipitous decrease in the number of cases because people at that time were adhering to the health officer's orders. But now, that plus the gatherings at Thanksgiving all have contributed to the increase in number of cases. But this is not just San Diego. This is throughout the state, throughout the nation. People have just developed COVID-19 fatigue. So those are the factors that are contributing to our increased number of cases.
Thank you. And then the demographic, if we have an idea of those that are filling the hospital and ICU beds.
Well, I actually just shared with you that individuals that are hospitalized, the demographics is over 70, almost 80% are 50 years of age and older. And you can find the information on our website. For cases, hospitalizations, and deaths, we do the ages. We do age, gender, as well as the race and ethnicity of those three categories. So that information is posted every day.
Perfect. And does the nurse to ICU ratio changing, Dr. Wooten, will that impact our numbers? Do you see that happening, or are you still very worried about the capacity here in San Diego?
Well, we are all worried about the ICU capacity, not just in San Diego. That's a concern, not just again in California, but across the nation due to the increase in the number of cases. We hope that by the nurse to ICU patient ratio change, that will help. But there are other factors that must be employed as well, as Supervisor Fletcher already mentioned some of the things that hospitals are doing. So many factors will have to, the levers on many factors will have to be pulled so that we can make sure that there are beds available. Thank you.
Thank you.
Okay, next question.
Lisa Halverstadt, Voice of San Diego.
Hello, thanks for taking my question. So the county's hotel program has included rooms for both people that have coronavirus or have been exposed to it, but also some rooms for people that are considered high risk, especially those who are homeless. I'm wondering, given the high number of cases at the convention center shelter and obviously across the larger community, where do things stand with those rooms for people at risk? And is the county looking at expanding the availability of those rooms at this time?
Okay, Nathan Fletcher is going to respond to that. He's been working very closely with the convention center folks.
Thanks. I think the increased number of cases at the convention center really reflects what's happening community-wide. We have worked since the beginning to make the motel rooms available, initially out of a public health desire, and we're seeing massive increases in utilization or significant increases in utilization from COVID-positive people or people who have to quarantine. And we have worked as best we can to try and make those rooms available for individuals where the convention center was not an appropriate location, working initially with the Regional Task Force on Homeless to have a few hundred rooms available, along with partners in North County and other areas. We are working with a lot of the individuals involved in homelessness about how we might increase access to those rooms for individuals, along with figuring out other types of things we can do to try and address the situation. And we do remain confident that although we are seeing a spike in the convention center, there are good systems and protocols put in place. And it should not be assumed that if those individuals were not in the convention center but were congregating on their own, were in hotel rooms, that they wouldn't face the same dangers of community-wide transmission. So we are taking seriously what's happening in the convention center and working to make sure we do everything to address that. And we are simultaneously working to see what avenues or paths may be available to open up rooms for individuals who may be at higher risk. So we continue to work on all of this.
And is there any specific partnerships that are happening or efforts to amass additional rooms that could be accessed?
Yeah, we continue to work on efforts to increase the availability of them, looking at possible ER discharges as one avenue, looking at ways we can better allow homeless outreach workers to be able to access those rooms. There are a variety of ways, and we're exploring all of them.
Thank you.
Okay, next question.
Brandon Lewis, Channel 8.
Thank you. I have two questions. To the end of the year.
Okay,
Brandon, please repeat your question.
You're breaking up. Try it again.
Thank you. Yes. I was wondering, as we get to the end of the year, how does COVID rank among leading causes of death in the county? And second, to expand on staffing concerns in ICU, obviously we can't wave a magic wand and make trained people appear, but what, if anything, can the county do to help make sure more staff are available, given the number of beds that are available, that are in the county, basically?
Dr. Wooten's going to respond.
I didn't hear the second question, but regarding where COVID lines up with the leading causes of death in San Diego, it hasn't changed since the last time that we showed data through the end of August. And I recently looked at this data last week, and we can make sure that that is posted somewhere on our county website, but it's still about number 6. It has been vacillating between number 6 and 7, but last we looked, again, number 6.
Thank you, Dr. Wooten. My other question was about whether the county can do anything to help make sure that more of the available bed space in ICUs have staff to run them. We've heard that staffing concerns are a big issue among hospitals.
So we have Dr. McDonald that will answer questions about the ICU beds.
I'm sorry, I'm going to have to make you repeat that question one more time since that was dual tasking there. So the question had to do with the staffing of hospital beds. So you just repeat that for me.
Yes, Dr. McDonald. So just wondering what, if anything, can the county do to help make sure that more of the available bed space in ICUs have staff to run them, given that we've heard from several hospital groups that staffing concerns are a major issue?
Well, primarily this is an internal staffing issue for the hospitals. They have access to temporary staff. They have staff that they are offering, sharing between each other. They also have plans in place to be able to redesignate staff. That's to say staff that would normally be in one role being able to be easily transitioned to another, say somebody who might normally be working in anesthesia, being able to support certain specific ICU tasks. That is actually best managed by the hospitals. Now, of course, there are backup systems to that. There are if a hospital had to access outside itself and beyond their partners within the county, they could use the Medical Reserve Corps. They could be accessing other temporary services, but we're not quite at that stage yet.
Okay, thank you, Dr. McDonald.
Okay, we'll go to the next question.
Matt Hoffman, KPBS.
Relating to Brandon's last question about the ICU situation, can you just break down the available beds in our county versus the available beds with staff? I know you said, guys said last week that hospitals have a plan to increase staffing, and just wondering from your point of view, that just in the last 7 days, if that's happened.
Okay, I'm looking, I think Rob Sills is going to respond to that. He's our facilities guy.
Thank you. In regards to ICU bed capacity within all of our hospital systems, that's a number that we track on a daily basis. And there's a difference between physical beds and then staffed beds. And as of yesterday, our staff beds that are readily available for patients sit at 24 within our county. And our hospitals have a number of patients within the emergency departments that qualify for these ICU beds that are being held there, and they're waiting. As you can see from the slide that Dr. Wooten, or I believe Supervisor Fretzer went over, you can see that there are the number of total licensed beds, and our current ICU capacity is at 696. And then the one thing to note about this is, for the first time, we just passed the 50% mark. So more than 50% of all of our ICU patients are now COVID patients. So that you can see the trend line that is going up there. So I hope that handles your question.
Yeah, sorry, just follow up. You said staff had said at 24% available, and I know, like, obviously 0.5%. I mean, that's a pretty shocking number. I mean, does that just mean everybody else around us is just like super, super low, no ICU availability?
Okay, I think I'm understanding your question. You're talking about the regional numbers that the state has been pulling up, correct? Yeah, and again, you see that the southern region, we're in a very large grouping, and both Imperial County as well as Riverside and San Bernardino County, they are having a very low number of ICU beds that are staffed and readily available, and so that shows the number for all of us.
Gotcha. And then I just one other about testing. I know the South is just a library site, moving to appointment only. Is that because you guys are just doing a ton more testing? I know that's a trend that's been happening at some other sites as well.
Matt, can you repeat that question again for the South Bay Chula Vista Library?
Yeah, I know the South Chula Vista Library COVID testing site is moving to appointment only. I know another one did last week as well. Is that because you're just seeing like a big influx in testing? And then sort of how does that play now that we start seeing some vaccinations?
Yeah, great question. Primarily for the number of sites, those locations, Aquatica was another one we had to move to by appointment. It was primarily because of the volume of the cars backing up from a safety perspective. And so we wanted to manage that so we get people in safely. That was the primary. The second issue is that we have capacity elsewhere in our testing sites. So we can constantly refer people to 211, letting them know. As it relates to the vaccination for COVID vaccination, we have not identified any of those sites yet. That is part of our planning that we're going to do in the later phases, as Dr. Kadakia talked about. We get out more into the community. But that is the reason why we moved to the by appointment for those sites.
Thanks.
Okay, we have one final call-in question.
Paul Sisson, San Diego Union Tribune.
Thank you. It appears that many of our healthcare facilities, many of our hospitals in the county have been at 0 or 1 or 2 staffed and available beds for several days in a row now. I just don't understand how those facilities are able to continue to cope in a situation where it doesn't appear day to day that they're identifying or flexing in more staff in the ICUs to get back above 0 again. How are they able to cope in this 0 remaining or 1 or 2 remaining kind of ICU bed situation that they're in?
Okay, Rob Sills is going to respond to that.
And Paul, thank you for that question. It's, yeah, I mean, the hospital, each of the hospitals have their own operations. They have their own surge plans. And the numbers you see, you remember there are patients that are discharged every day, as well as patients that are coming in. So it is a very fluid situation. And each of the hospitals are making a determination of which patient best fits the need to provide that level of care for. And then when a patient is has improved and is able to be discharged, they'll be discharged down to a lower acuity bed, making the beds available. So there's a constant flow of patients in and out of this. So that's, but just overall, if you remember, Paul, it's just over time, that percentage has just gone down, and they're maintaining operations, and our hospitals are doing a very good job working amongst each other, and with the communication and the resources, and ensuring that the best appropriate care is provided for patients. And I think Dr. McDonald has some additional comments.
No, I just wanted to quickly add, having spent decades working in an emergency department and understanding the flow from pre-hospital to the emergency department into the hospital, whether it's a ICU bed or a medical surge bed, and then back out of the hospital to skilled nursing facilities or back to home, we hope. There's a flow of patients, and at any one time when you have this many patients going through the system, there might be bottlenecks. And there's been a system in place in the county for over a decade, the All-Hazard Health Services Capacity Task Force, which works together, has been activated since March, and allows the systems to work with each other. You know, in normal days, one Scripps hospital would simply transfer a patient to another Scripps hospital to allow this, what I would call decompression, to occur when one facility is having an overload situation. But what's happening now, and frankly what's been happening for quite some time, is that the hospitals are working together between the systems in a way that is, I would say, unprecedented for this period of time. Really every hospital, including the federal ones and Rady Children's, are all working together to sort of manage this flow day to day. So you know that the two hospitals in Chula Vista, for example, have really borne the brunt of many of these cases, and they've been able to, what I would use the word, decompress by sending patients from the pre-hospital system straight to other places, or if they're in the ED, then finding a bed in another hospital. And that's a lot of coordination and effort that needs to occur both on the county EMS, emergency medical services side, but also between the administrations of the hospitals to make this happen.
Thank you. And so in terms of overall erosion of the standard of care here, I mean, the fact is that you've said you have patients backing up in emergency departments that don't have beds on units, whether it's medical and surgical or ICU, you know, and you've also said that now we've got, you know, a little bit broader nursing ratios, so we have nurses taking care of more patients than they normally would. How does the county oversee this and make sure that the standard of care is not eroding any more than it absolutely has to in this kind of crisis, or maybe it's not a crisis, but in this you know, unusual situation that we're in right now?
Well, again, the reason that all this is occurring is so that the physicians who are on the front lines can maintain that standard of care. And that standard of care is being met now, and it's all the things that we're doing process-wise that have that as the ultimate goal, to be sure that the standard of care does not drop. Now, there are contingency plans always in place for crisis management. We're not there yet. There have been other counties that have come close to the brink of that. We're not there. But again, that is also something that the leading physicians, intensivists, and medical ethicists at each of the hospitals have also talked about. But we don't want to get there. We want to actually do the things upstream, and that's why we're asking the public to do the things that are in the public health officer order to make sure that this downstream effect doesn't, in fact, impact what is, you know, world-class care here in San Diego.
Thank you.
Okay, and Dr. McDonald, this question is from Kelsey Christensen with Fox 5. She asks, how accurate are new COVID-19 in-home testing kits? How do they work? And the third question is, since the county does not count in-home test positives, do you recommend that residents do the in-home tests, or if they're feeling sick, or go and get a PCR test?
You know, those are great questions about a new test that has been FDA authorized. I have not looked into the specific sensitivity, specificity information on that specific test, but I can say that if the FDA has authorized that test for use in this way, that it has certainly met their standards and is now among the options that the public can use to get a test, and it clearly would be convenient at home. Because those tests have just started being done, I'm unaware that we have gotten direct results from those tests at the county health department level, but I will say that both in the state and nationally, there's a requirement that all tests are resulted positive and negative. That gets reported to the local health departments, and the national company that is fielding those tests would be sending those results to the state and then to us so that we could act on them. We do act on all tests that are positive that come to us, whether it's a PCR-based test or it's an antigen-based test. We report in our briefings here only on the confirmed PCR-based tests, but in our weekly COVID Watch, we do actually talk about the number of antigen tests that are done in the county, and then we do act on those as positives for public health purposes.
Okay, and this question is from Jared Ahrens from ABC 10 News. He's asking, what security measures are in place to protect the vaccines and make sure they only go to the places and people that they're supposed to, and that no one can jump the line to get vaccinated?
Well, certainly at this point, we are having delivered to us the vaccine to very specific locations. That's why we don't mention where they are, because they are under lock and key and guard and appropriately stored. The hospitals themselves have determined the priorities for their own staff. As mentioned at this point, it's only hospital personnel that are being vaccinated, and we hope to be able to meet that need and move on to the lower tiers quickly. As the number of those eligible to be vaccinated expands, we will certainly be continuing to track that very closely, but right now we're relying on the prioritization of the hospital providers themselves to tell us who the most critical people are to get those vaccines initially. All those vaccine tests, of course, all those vaccines, I'm sorry, get recorded into our Immunization Registry, so we are able to track it in that manner.
And it was a two-parter. The other part is, what lessons did the county learn from the Hep A outbreak and vaccination effort that could help when it comes to making sure people get both doses of the COVID vaccine?
Well, the hepatitis A outbreak gave us lots of lessons across the board. Certainly gave us an opportunity to reach vulnerable populations with vaccination. So we're certainly going to leverage that experience so that when those vulnerable patients and populations are in the right tier to get vaccine, we will use those same techniques to go ahead and reach them. Also, we learned a lot by utilizing our Immunization Registry, both for making sure that no one got unnecessary repeated vaccinations that they shouldn't be getting, and also got their second vaccine on time. And we learned simple things like certain populations, a piece of paper or a card is the best thing to remind somebody to come back. Others that are maybe a little bit able to respond to technology can get those reminders. But we had very good success both with initially reaching vulnerable populations and then repeating those vaccinations in those populations with hepatitis A, and we anticipate that that will happen with COVID-19.
This next test question deals with using other medical professionals to administer the vaccine, and Dr. Wooten's going to respond to that.
The question is from Abby Alford with CBS 8. She asks, what is the county's thought for allowing dentists and optometrists to administer vaccines to help get more people vaccinated? And she also asks well, why don't you answer that one first?
Well, thank you for that question. We have previously asked for a waiver from the state for paramedics, for instance, to provide COVID-19, to obtain COVID-19 testing. And we certainly did that during hepatitis A outbreak. We requested a waiver from the state for paramedics to provide Hep A vaccinations. For dentists and hygienists, that is not currently in their scope of work. I think, first of all, that should be a statewide discussion, and then certainly including the industry association for dentists here in California. But currently, dentists do not administer vaccinations, so again, that would require statewide effort, and the state would have to waive or allow dentists to do that as part of their scope of practice.
Okay. And the second part of her question was, how will people know when and how it is their turn to get the vaccine? Will their physician notify them? Will the health care provider notify them? Or will the will the county notify them?
So if staff could put up the phases for vaccination, the general public is not going, the general public will be in the last phase, as is noticed there, unless they fall into one of the other phases or tiers within, say, for instance, Phase 1A. We will announce the information just as we do any other situation that we have where the public needs to take action. Just as we have announced where people can get tested, we will announce where people can get vaccinated once those locations are identified. Oh, and one other thing, probably patients of healthcare systems. So the healthcare systems would also let their patients know, because really the healthcare system is the primary location where the general public goes to get their preventive care services. So, but again, that information would be announced once we hit that phase or reach the phase that is designated specifically for the general public. Thank you.
Thank you, Dr. Wheaton.
This next question deals with whether there's an ability to get medical professionals from other hospitals in other parts of California, and also dealing with the Palomar Hospital when that facility will be stood up. And Rob Sills, our Director of Medical Operations, will answer that question.
The question is from Claudia Buccio with Univision, San Diego. She asks, as a strategy to deal with hospitalizations, is the county seeking more staff from other areas in California, or are hospitals training nurses to be able to treat COVID patients, or just postponing non-emergency procedures? And she also asks, is there any word as to when the Palomar Health Emergency Hospital beds might be activated? Will we have the staff for it?
Great, thank you. A lot of staffing. As Supervisor Fletcher mentioned, staffing is key here. And in my conversations with different hospitals, they are all, and they started months ago, putting in plans, for training nurses at different levels, to train them up, to make them more familiar with the equipment and procedures necessary and maybe a higher acuity level of care than they are traditionally used to. And in addition, part of our operation, sorry about that, is we talk amongst ourselves within counties. We're in a southern region. Again, we talk with the different counties that surround us for staffing, as well as other resources when those are needed. And then we have another lever we can pull, and we can submit staffing resources up to the state. And we have done that, not at the hospital level, but at long-term care facilities. We submit requests, staffing comes down to assist there. I believe the other part of the question had to do with the Federal Medical Station or the alternative care site up at Palomar. And yes, that is a great option. There's a great option. It's inside of a hospital, so they could use the other facility, the other aspects that is needed in a hospital, like X-ray and other things to treat these patients. So that is a very good option. And I believe the question had to do with staffing. We're working very closely with the leadership there at Palomar in their staffing. And when all the hospitals agree that we need to open that up and use it as a community resource, then that lever will be pulled, and they'll work on providing the staffing that's needed for those beds. Thank you.
This next question deals with the ambulance division, and I'm going to ask Rob Sills if he would come back up here to respond to that question. Or no, I'm sorry, Dr. McDonald is going to respond.
The question is from Jacqueline with Fox 5. She asks, can you please tell us about the county's new ambulance diversion and how important it was to implement the new procedure?
Yeah, thanks for that question. That was one of the things I was slightly referring to when I was answering Paul Sisson's question about the management of pre-hospital. We've always had a tool available in our hospitals to, quote, go on bypass. That is, when your beds are filled and your staff is reached capacity in terms of how many patients to take care of, you can notify the EMS system here in San Diego that you're on bypass. And so most of the patients would go to other hospitals that aren't on bypass. There are still some patients that can come through to you at your location with in this normal bypass system, and so the hospitals worked closely with our EMS medical director, Dr. Christy Koenig, to come up with another tool they can use to be on what we call complete bypass. That allows a hospital who really can't take any patients at all, even their own that would normally be in their system, to be diverted to another location for care. So this new tool is just one added level of ability to manage patients in the pre-hospital space, and that was a new tool that was available and used a couple times by some hospitals over the weekend to good effect. Again, it's meant to be something that's only temporary while they are able to do the things internally at the hospital to be able to go back to caring for patients, particularly within their system, and then obviously to all comers coming to the hospital.
Well, due to the time, I think we had one or two other text questions. We won't have time to respond to those right now, but we will get back to you with a written or texted response to you. As you all heard, our hospitals are really being hit hard right now. And I want to remind those of you who used to work in the medical profession that there is a way to offer your expertise through the San Diego Medical Reserve Corps, and I think Dr. McDonald and Dr. Wooten have both made reference to that group. The San Diego Medical Reserve Corps is a community-based group of local medical and health workers who can serve as volunteers during a local health emergency. If you are a retired physician or nurse and previously worked with one of the local healthcare systems, we would ask you to please consider contacting their HR department if you have not done so already. If you are retired or not working right now and can help, please go to healthcarevolunteers.ca.gov and sign up. Unless conditions change, we will provide our next update next week on Wednesday at 2:30. Until then, please watch out for your fellow San Diegans. Protect yourself and protect your families and your neighbors. And again, we thank you for your attention. Thank you.